Hi, Jose.
Hey, sorry. How are you doing?
Oh, I'm fine, thank you. Yeah,
Hey,
yeah. Sorry about all this confusion. It's all
yeah,
about the summertime change.
I know. I just put here this flyer with the 1 p.m. GMT because the flyer said, or it says 1 p.m. London and Lisbon.
Lisbon, yeah.
No, it's not. It's different from GMT because of time change.
This morning
So
is changed, unfortunately.
I know it created a big confusion, even for me. I thought everybody was delayed. That's why I called you. Where are you?
So this morning I got up and then I had this confusion. So that is why I texted you and Fasil. Emailed you and Fasil to see what's going on. I think everybody was confused.
Right.
Then I thought that actually it is 1 hour behind. So I thought we will be starting at 12 instead of 1 o'clock. Then
Exactly.
somebody corrected me. It's not 12, it is 2.
Yeah.
Then
Yeah.
I received your call.
Yeah. In fact, for us, it's 2 p.m. instead of 1.
Yeah.
Yeah.
I don't think we have the speakers logged in yet, is it? Rachana and
You are a co-host now also, as you can see.
yeah.
I don't think so. I'm looking
No.
for
Okay, I'll
them,
just
participants, and I can't find them.
I told them we'll be available half an hour before.
Mm-hmm. What time is it now? It's 1:37. Okay.
Yeah. Still got time.
Yeah.
So how is Lisbon?
Man, much better. We had a difficult February, as you know, because of the UK strain that we had here. The numbers, raised up really fast. But then in 3 weeks, the numbers just fell down, and
that is good news at last.
Having like 500 cases a day, not more than that, which is amazing.
Let's hope it stays like that.
Yeah, we are opening the things now. The restaurants still closed, but primary schools are open. Some kind of offices are open now, but it's terrible for economy, as you know. Yeah,
it is. Can't believe it's been a year like this, isn't it?
Yeah, exactly. How is it in UK?
Things, we had the second wave, but things seems to be quieting down. The primary schools have opened, and I think from 1st of April, we'll have more activities. We are increasing our national health theaters time more from mid-April.
Okay.
And from mid-May, we'll be back to normal. That's what we are hoping now.
It's good.
I'm saying for now, because you never know what is going to hit again.
Yeah, this is a problem. You have plans and then suddenly everything changes.
Yeah.
And what about private practice? Can you do surgery?
Yeah, I think for 3 or 4 months, it was totally shut down last year. And since then, it's been to almost normal. We are not doing people with a comorbidity, even any sort of comorbidity, even with asthma, the anesthetists want to touch. But otherwise, reasonably healthy youngsters, we are doing everything.
Oh, Alvin is here. Alvin, are you there?
Hi, Alvin. Is he muted?
He's here, but he's muted and video off. So probably.
I think probably he has gone.
Yeah, just open it and.
Yeah.
I'm inviting him to unmute, but it probably is not there. Let me see if Hashem is here.
Oh, Jonathan Bruce is there. We need to bring him up, isn't it?
Who? Oh, Jonathan is here, right?
Yeah.
So I'm going to.
Jonathan Bruce is there. Hi, Jonathan.
Hello, Ulas. So we're due to start in 20 minutes, yes?
Yes, they are. Exactly 2 o'clock we'll start. So
But you have a lot of people online already, so...
Oh, they have been waiting for an hour now because of the same confusion we had because of summertime change.
So, yeah, so 1 p.m. GMT is not quite yet, but I got the maths wrong in the other direction. So first we thought it was 11, and now we think it's... can I share my screen?
Yeah. You are a co-host now. I'm going to stop sharing mine. Okay.
Oh, Regina has come as well. Hi, Regina. You're muted. You're muted.
Right. Oh my God. The whole... Okay.
Yeah, here, now I can hear you. And Alvin?
Hi, Ullas. I logged on about an hour ago.
See, there is a confusion about this summertime.
I know.
Yeah. So this morning we were trying to rake our head whether we are 1 hour behind or 1 hour forward.
I know, it's not easy, is it?
You make me the host, then I can start sharing my slides. Or am I sharing my slides already?
Nope. We can't see yours now.
Okay. Let's see, where are we? Okay, share screen. But now you should be able to see my slides, yes?
Yes, I can see it now.
Yeah, good.
Lovely.
Perfect.
Yes, we are seeing yours now.
Hey, Fazil.
Hi, Carlos.
Hi, Faisal. How are you?
Hi, Ulas. Very good to see you.
Right. So we have both Regina and Jonathan here. Jonathan is sharing the screen at the moment. And the lady you're seeing there is Regina Mukti. Faisal is the past president of the European Academy of Facial Plastic Surgery. And Carlos below is the secretary. Am I right, Carlos? You're secretary now, aren't you?
Yeah, general secretary, yeah.
Yeah, of the European Academy of Facial Plastic.
Carlos, where do you work?
Lisbon.
Have we not met you at the IMO? Did you not give a talk on?
Yeah. I did, yeah. And
I was very impressed with your talk.
I did, yeah. I performed eyebrow lift, remember?
I think if once we have the end of lockdown and the end of Corona, Rashn and I would love to come visit you in Lisbon and spend some time. I think you were running a course as well.
Yeah, I do. It's my face academy, but we needed to postpone this year also. So next year, you will join us and you do something for us also, okay, Jonathan?
That would be lovely.
Great.
Ullas, would you?
Yes.
Because there are some people obviously who are ahead of schedule, but then there may be quite a lot of people who are, going to log on in 17 minutes. Do you know how many people we're expecting?
Usually we have around 200 people.
Yeah.
So I don't think it's a problem accommodating them.
Do you want us to start? Or should we run it twice? It's not such a long talk. We can give it twice.
No. Let's wait till 2.
We'll wait for 2.
Let's enjoy a little bit of chat.
We are very honored to be allowed to speak at a facial plastic surgery meeting because we're oculoplastic surgeons. So in some ways we feel like the little brothers and sisters of the big facial surgeons. So I was going to put on a tie and everything, but then I heard my phone ring and Rajat said they're all online. And I'm like, what's going on?
We forgive you this time, Jonathan. No problem. Next time, you should be more proper.
So Jonathan, I opened the Zoom as I usually do, before the scheduled time, and nobody was here. Now some participants, but nor Ullas, not you, nor Rashna. So I was like, where are the speakers? Where are everybody? It was 1 p.m. So I called Fazil, I called Ullas, what's happening here? Okay, the time changed. But the thing is that we wrote here that it would be at 1 p.m. London, Lisbon, and now it doesn't, goes with GMT, which is also a mess.
So England went into British summertime overnight, but in Europe,
us. It's like us.
You also.
Yeah.
Okay. So we're the same. So you also thought it was 2 o'clock.
Yeah, that's
Okay.
Yeah.
But you logged on an hour early just for fun.
Yes, but nobody was here. That's why.
So I wrote to Ulas and I said, "Oh, look, there's British summertime, so it's going to be 11 instead of 12." So I did the maths the wrong way around. So we thought it was going to be 11, and then at one point this morning, Rach and I did not know if it was in 4 hours, 5 hours, or 3 hours. So we were giving the talk.
So the thing is, Jonathan and Rachna, you need to repeat the same talk an hour later again.
Okay, we'll repeat it every week if it needs to.
Or what we do is we record it and then we just play it on a loop.
Yeah, why not?
Actually, this is pre-recorded. You're not speaking to us really, so this is one we did an hour ago.
Ulas, can I ask where do you work?
Me, I'm split centers. My NHS work is in Doncaster Royal. My private work is in Manchester.
They're not that close.
Certainly not. It's only 100 miles.
Okay.
Fazil, where do you work?
I'm from Izmir, Turkey.
Okay, cool.
Oh, it's there.
So we have some very talented colleagues who are in Turkey. Do you know Altuk Çetinkaya and Onur Könük?
Actually, no. We're trying to establish a connection with oculoplastic surgeons. The problem in Turkey here is, unfortunately, our plastic surgeon friends giving them a hard time. So they're trying to approach us to be existent, you know. So it's a kind of a problem here now still.
And so we know three. There's a lady called Pelin Kaynak. There's Onur Könük and Altuk Çetinkaya.
Probably they're from Istanbul and they don't have any connection with us, unfortunately. And we last year we have a new group. Carlos is very good to tell us we should have an oculoplastic group. Actually, 2 years ago, right, Carlos?
Yeah.
So we had the chance to integrate Carlos Ramon Medel and Naresh Joshi. And with the help of Ulas, we're having you now. So we're very happy with that.
Thank you.
And Naresh Joshi is a big supporter of Rachna and me. We're actually going to go visit him in his London theatre in April, just to pick up some tips. Rachna actually trained with Naresh many years ago, so she was one of his fellows.
Okay. Naresh, he's a great friend, great guy. We like him very much. He's always very supportive. And yeah, we're very happy to have him with us.
As is Ramon Medel. I mean, Ramon invited Rachna to speak at the same meeting that Carlos was speaking at, and Naresh. So, but I find it's nice to meet people. When we go to meetings where we have lots of our friends in England, we don't learn quite as much because we all have been taught the same things by the same people. But when we reach out to other specialties like this, you know, the world kind of opens up and we go, oh my God. There's so much we don't know.
It's a great idea. Actually, are you coordinating with other specialties as well for your webinar series, or is it just?
Yes.
No, it's brilliant because I think crossing the bridges and the boundaries between the different specialties is what's so.
We are very open. Only among us, Alvin is the stubborn one. Otherwise, we are very open.
Oh, that's great.
I'm trying to tease Alvin to open his mic, so that is the reason I'm doing that. Alvin, join us.
Very much.
Alvin is our president-elect. He's going to be the president in a few months.
I'm listening to you all guys chatting away.
Alvin, are you also based in England, or where are you based?
I'm based in London, actually.
In London, right?
Yes. Yeah.
But his son is in Oxford.
Uh-huh.
It's a good place to be. That's where I picked up my wife.
Well, there we go. So, yeah. No, it's been great to have you all guys. So I think
you can say that after we've given the talk. You might say, "Oh my God!"
Well,
we're coming back for a second installment apparently. So at least now you have the chance to. You've had a taste. You can always pull out and say, we're fine, thank you. That was very great.
That's why I put 3-week break there.
You'll have to deal with Ulas. He's a proper surgeon. You know what it means.
Instead of next week, I gave a break of 3 weeks so we can have time to sit down and analyze how Jonathan and Regina has performed today.
We can also adjust to the time zone change.
Oh yeah, by that time it should be okay.
It might take a while, you know, it's a big thing.
Ulas, Anju was very scared of Jonathan and Rashna. I don't know why.
Why am I scared?
She
Why should I be scared?
No, Anju, Anyana, she was very scared of both of you
Anju,
guys.
oh yeah.
I don't know why.
Anjana.
Yeah.
So,
I trained with Anjana in Cambridge, actually. So we both worked for Rachna before.
yeah, I'm the old person here.
Hard to tell from here. You look younger.
Naresh is even older, so that's fine. That's the only thing keeping it going.
This is how we keep this. This is how we keep our friends.
Did you find the name of the private company they have floated? Regina and Jonathan. It's called the Face Restoration.
Well, we've just launched it actually. So
Is it?
yeah, so it's a brand new venture. But very exciting.
All the best for that.
Thank you.
Yeah, I was thinking actually, just because we're sitting here and we have to spend some time, I thought what I might do is I'll just these are our disclosures, and so Rachel and I have spent lockdown doing a few exciting things. We've started a filler and surgery training academy in Cambridge. We've started our private clinic in Harley Street in Cambridge, and we're also opening in Wimbledon. And then Rachna has very intelligently come up with this amazing cleanser, which you can spray directly on the face, and it's eye tolerable. So it's the same pH as the eye, and you can just spray it on your face. And it's let's see, I probably have a bottle.
It's an antimicrobial. I think it will be the future of skin asepsis, but at the moment it's
basically it kills all viruses and all bacteria pretty much. We can't say the names of a particular virus, but there's one going around at the moment, which means that we are constantly spraying this on ourselves, and it doesn't sting, and it's lovely, and it's based on something called hypochlorous, which is an oxidizing agent, and so we use it when we give our fillers, we use it for post-op, and it basically, yeah.
It'll be relevant for ENT, actually, because they'll be bringing out probably a nasal mucosal one as well, so you'll hear more about it in the future. It's used by dentists, it's used by skin asepsis. But,
one reason it's exciting is because, as you know, that the microbiome is being shown to play a role in all kinds of eye diseases, thyroid eye disease, certain forms of uveitis. It's involved in bacteria responsible, for all kinds of things like ulcers, etc. But the microbiome, and particularly changes in the microbiome, are going to probably be the next big thing in medicine. And this is one way of affecting it. So I say we, Rachna's included me in it because she's generous, but it's really her idea, and she's been absolutely brilliant about it. So that was our plug.
Thank you.
Do you have any videos?
We do.
Have some videos.
Yeah, we do. It should run.
Yeah, it should run. Okay. If you want to try, we still got time. We've got another 6 minutes to go.
We're giving away all of your wonderful slides.
Yeah, but we're being quick about it.
Well, that's the one behind. You can try that one. Yeah.
Yeah, you're seeing that, right?
Yeah.
It's moving.
Oh, yeah.
Yeah, that's good.
Fantastic.
See it all. Yeah, see it all. Let's escape so that you don't give everything away.
So both of you will decide among yourself what to say, isn't it?
Yes.
Unless you want to do it for us.
You're welcome.
No, it's a joint act, isn't it?
It is. We're always a double act. No, it's good. You're welcome to give the talk if you like, but I think we'll try and manage.
It's not that long, but what we realized is that you guys are the experts on facial surgery, so it's unlikely that eye surgeons are going to come along and teach you anything. So we've tried to include things that you'll find interesting, if nothing else.
Friends, I just wanted to welcome our Academy's president, Hesham Saleh. Hey, Hesham.
Hi. Hello, guys. I
Hello.
realized the time changed. Nice to see you, Jonathan Rachana. Ulas. Yeah, but I realized in the last minute, so that's good. I'm here now.
No, but you got it right though. You're the person who's actually it's you're meant to come on in 5 minutes. It's
Exactly. No, the funny thing is, I was giving a lecture in Canada, and they gave me the wrong time on Friday, and I wasn't ready. And they said, "Why aren't you on?" And I was in my clinic, but we managed to do it. Always confuses everybody that change in time in England.
Oh.
Are we good now? Well, nice to see
Hesham,
you.
where do you work?
I am in Charing Cross
Oh,
Hospital.
wow. Okay.
Yeah, London. Yeah. So, no, thank you for coming. I heard you saying that we don't learn from you. We always learn from you guys. So we definitely do.
Oh, it's an honor. Thank you.
Thank you. So I think we're about to start.
Mhm.
4 minutes to go.
Here's Alwyn with his music. Alwyn, hi. We could see you.
Hi, Hesham. You all right?
Yeah, very well.
Hi, Shem.
I'm here, Fazil, as well.
Welcome.
Well, there we go. The whole team is there now.
Everybody's here now.
Numbers are going up. What are we now? 40 something?
66.
66 now.
My eyes are going. So,
So, Fazil, how are
Rachna,
you?
is everything looking okay from your side? So are you seeing our talk? Yeah.
Looking great. Yeah, it's all good.
Yeah.
We saw it when it was on, yes.
yeah, I think it's very good. Yeah.
Carlos called me an hour ago saying that, Fazil, we must be starting now. I said, I'm in another webinar.
We were just saying this. Yeah,
He
everybody's
said,
confused.
no, we should go. I said, I cannot because I'm the moderator of a session.
Yes,
And then I called Ulas. Where are you? Where is everybody?
yeah. The time.
Ulas wrote to me yesterday about that. We said the GMT is the real time. All the time. So GMT never changes, thank God.
We could always, we should always use a GMT because it just gets confusing.
I think
every time.
the European Union is getting rid of summertime. So this problem will
Not in England, though.
not in England, no. No,
Because
but Europe,
what it changed
Europe has
last
gotten
time.
rid of England.
Yeah, get rid of England completely, yeah.
Lost my co-presenter.
Oh,
Oops.
geez.
Rachna, you're muted.
It's okay. I had to make sure that the kids were locked away. I'm kidding.
Yeah, one more.
Carlos, I love your backdrop. It's fantastic.
Oh, it's Lisbon. Thank you.
Very nice.
I've been to Lisbon, to that beautiful fort, which I don't, maybe it was King Henry the Navigator had, with the animals on it, and that sits out. And I ate these. Was it Torre de Belém and Tarte de Belém?
Belén's Tower, yeah. Torre de Belém, yeah.
And there were also little cakes of Belém that you could eat.
Yeah, it's called Pastel de Belém.
Still de Belém.
Yeah,
They are dangerous, Carlos.
they are. You can eat like 4, 5, 6 in a
10,
row.
20.
They are so good. They are small, but they are very energetic and very sweet.
Well, we definitely should be having a meeting in Lisbon then when things open up.
Yeah, we need to organize
We
that.
had 3 years ago.
Okay. Oh, wow.
Carlos, do you still have these angry killer whales swimming off the coast and sort of attacking boats, or is that finished?
No, we have dolphins, but not whales. No.
Sharks?
No sharks. Thanks
No.
God. Our beaches are very safe.
If we are allowed to go to any beach, I just need the beach as soon as possible.
I think there's a last week's presenter. Is that Anjana?
Yeah.
Yeah.
Because it says J Haridas. But I think that's a Mr. Haridas.
Can you hear me?
Yeah,
Now we can.
Hi.
I'm in my sort of informal zone, making myself a cup of tea.
So are we.
Angela, it was a really nice talk you gave last time.
Oh, thank you. Yeah, well, I was just the prequel.
Well,
Fasil, shall we start? It's 2:00.
I think so. It is time. We have about 80 participants now, which is fine. It's going to increase in a few minutes. So I think, Ulas, it's time for you to start.
Okay. Welcome everyone to the third lecture of the Blepharoplasty for Beginners series of webinars from the European Academy of Facial Plastic Surgery. We had 2 talks so far. One was on basic anatomy of the eyelid, and the second one was a bit more advanced anatomy, both given by Mrs. Anjana Haridas. And I'm sure that all of you liked the talk according to the feedback I have received. So we are moving forward, and we are having more discussion about anatomy of the eyebrow, which we have missed so far. And then we'll have the age-related changes and what is contributing to the age-related changes. And for this, today we have 2 excellent speakers, both are internationally acclaimed speakers, Mrs. Regina Murthy and Professor Jonathan Rose. Both are oculoplastic consultants, and between them, they come with 20 years of experience in oculoplastic surgery. They have already published 60 papers in journals like New England Journal of Medicine, Lancet, and BMJ. Both of them were trained in Cambridge, Harvard, Imperial College, Melbourne in Australia, and they work in Harley Street, Wimbledon, and Cambridge. And their clientele includes international movie stars, award-winning film directors, and globally recognized athletes. What more can we ask for? And I'm passing the mic back to Professor Jonathan Rose and Ms. Regina Murthy. Both of them will together present the topic today. Thank you very much for coming.
Thank you, Ulas. So Rash and I are honored to be invited to speak. You said it was a blepharoplasty for beginners, but we realized that we're dealing with the European Academy of Facial Plastic Surgery. And so we're hoping that whatever we say will be worthy of the audience. And if not, please forgive us. We have a few disclosures to make, which is Rachna is a key opinion leader and on the global complications faculty for Allergan. So in our private practice, we use pretty much exclusively Allergan products. We run a training course in Cambridge to teach filler and surgery in this periorbital area. We were just mentioning before that we have a spray that we market, which I shamelessly just try to sell to all the attendees. And we have our clinic, as you heard. So Rash and I are both oculoplastic surgeons. And what that means is that we really focus on this area. We sometimes venture out slightly, but this is our bread and butter, and it's the area that we feel that we understand. And we think it's the most important area also for you as facial plastic surgeons. And the reason for that is that the periocular area is a key area for everything we do as humans. So you may not know who these people are. You might, but it's unlikely. But if I show you these, you may well recognize Barack Obama, Brad Pitt, and Keanu Reeves. And what's very clear is that this area is where we spend most of our time looking when we first see a human. Alfred Yarbus was a Soviet or a Russian scientist back in the 1960s who did a lot of gaze tracking studies. And so each dot here and track represents where the eye is looking. So if it pauses, you get a dot, and if it's moving, you get a line. And what you can see is that when we look at a face, we spend a lot of time moving between the eyes, backwards and forwards, backwards and forwards. We venture out a little bit. Sometimes we want to have a look at the mouth because we may detect a snarl or a smile, but on the whole, most of the information we need to tell friend from foe, kindness, tiredness, sadness, all these things are conveyed by the eyes. And it's not just that, we can also detect the state. So I only need to show you this much of a human for you to be able to have a pretty good guess at how old they are. And all the other information down here is somewhat superfluous to the periocular area in terms of the brain absorbing the information we need. And we're so finely tuned at being able to analyze this area that we can even do it with toys. So you may not immediately be able to tell which ones of these Lego toys are male or female. But if I show you the eyes, you'll probably say that this is a female, this is a female, this is a female, this is a guy, this is a guy, and it's independent of what's happening to the eyebrows. And even when I swap the hair around on my children's toys, you'll still detect that this is a woman, this is a man, and this is a man, even though I've swapped the hair around. So we are very good at focusing on this area. So let's talk a little bit more about what's going on here. So this is the eyebrow, and it's got special hair that has a different telogen, anagen, and catagen phase than the hair we have on our head. So it doesn't grow long, and it sheds after a certain interval, and it's got a long static phase where it's not growing, where it's just resting. The eyebrow is divided up into the head, the body, and the tail. And below that, we have what Robert Goldberg at UCLA has called the brow fat span. And he considers this the most important part in a blepharoplasty operation, alongside the tarsal plate show. And the tarsal plate show, as I think Angela mentioned in the last lecture, is determined by the brow fat span. We tend to also traditionally measure something called the MRD1, which is the reflex distance from the pupil to the margin of the eyelid. And that can help us detect things like whether somebody had a ptosis or not. But in general, for cosmetic reasons, this is not as important as the amount of tarsal plate show. Now, the movement, so this area is obviously highly mobile, and there's only one muscle that actually lifts the eyebrow, and that's this muscle here, the frontalis, which tends to be divided into two with a sort of a less full area here in the middle. It tends to be asymmetric in quite a lot of people. Often in about 2/3, the right side is slightly bigger. And you can see here, it's an interesting muscle because it doesn't attach to any bones. It attaches into the tissue, the skin of the eyebrow, and onto the galea aponeurotica here at the top. And so it's not a bone anchored muscle, which makes it unusual. And as I said, it's the only elevator of the eyebrow. It's not an elevator of the entire eyebrow because it actually stops at about 2/3 out here. And that's why as you age, the outer part of the eyebrow tends to drop down because it doesn't have an elevator. It only has depressors that are not countered by an elevator. So that was our one elevator. Let's look at the depressors. So the main depressor, perhaps, is the orbicularis oculi muscle, which Anjana talked about last time. And it's divided up into three parts. It's got the pretarsal part, the preseptal part, and then the periorbital or preorbital part. It's a huge muscle, actually, if you look at its expanse. It goes about 1.4 centimeters above the orbital rim, 1.2 below, and 2.5 outside, as this image down here shows. So large depressor of the eyebrow, and very important muscle for communication. Another one of the depressors is called procerus. And procerus, when it contracts, gives us these little lines on our nose, what some people call bunny lines, but I like to remember it more as pork, because pork is pig, and pigs have these lines, and procerus is a bit like pork, kind of. And you can see this pyramidal shaped muscle here and here. And it inserts here on the nasal bone and then infiltrates into the levator in the skin. And then we've got two more depressors to mention. So we've talked about the orbicularis, we've talked about procerus. Now we've got depressor supercilii, and that one just lowers the head of the eyebrow, so it lowers that. And then we've got the two heads of the corrugator. The corrugator actually spreads out to about 2/3 of the lumen of the orbit, as you can see here. It's actually much bigger the muscle than one might think. The depressor supercilii is very small. You can see here it's hardly visible. And just to explain better the relationship between all these muscles, if we look here, the corrugator, which causes the corrugations here, so the angry lines, which you may not see because of all my Botox that I've had, but the corrugators, I try to remember that because it causes like corrugated iron, so it causes these sort of like things like you see on roofs. The corrugator sits deep orbicularis, procerus sits next to orbicularis and comes up to become sort of contiguous with frontalis. And depressor supercilii comes sort of from deep and emerges to insert into the head of the eyebrow. We also have nerves in this area. The supraorbital nerve comes out of the supraorbital foramen here, which can either be a notch or an actual hole. And it's in line with the maxillary foramen and the mental foramen here. So they all line up in a straight line. So that can sometimes help if you're trying to identify where they are. And the anatomy here can be somewhat variable. So as the supraorbital nerve comes out, through all branches of the trigeminal, as the supraorbital nerve comes out, it's got some deep branches and it's got some superficial branches. And the anatomy, as you see here in this study, can be quite variable. And then we have, of course, the supratrochlear, which comes out here, again, sensory nerve. And all these muscles we've been talking about are powered by the facial nerve, the seventh cranial nerve, which you see emerging here. The blood supply is fairly straightforward as well. It mimics the nerve supply somewhat. So here we, with one exception. So here you can see the supraorbital artery emerge, the supratrochlear, which has a deep branch which goes under the corrugator, and a superficial branch which comes out and goes through frontalis. And this will be important to you facial plastic surgeons who are spending more of your time up here than we are. Finally, here we have the temporal artery come up and the glabellar branch of the dorsal nasal artery here. So very rich blood supply emanating from both the external carotid here and the internal carotid in all the rest. The venous drainage mimics that. You can see here the angular vein, the supratrochlear and supraorbital, and they are draining into the internal jugular and the external jugular. And then we have the fat pads as well, which we wanted to cover today. So there's something called the deep central fat pad. I borrowed this slide from John Perry in the US. Here's the deep central fat compartment, and there's a deep lateral fat compartment on each side of that. And then there's this interesting little fat compartment, which is sort of contiguous and much larger than previously thought when you dissect it out, and actually contiguous with the deep fat pads. And it's called the roof, which is a clever name because it's the same as the SOOF, the suborbicularis oculi fat pad in the lower lid, but this one is in the upper lid. So it sits just behind orbicularis oculi here. And that muscle is, that fat pad is sort of interesting because it's thought that it may contribute to the differences in the Caucasian and Asian eyelid. So the teaching so far has been that this is a sagittal view of the lid, and you can see here something we call the orbital septum, and behind that you have preaponeurotic fat pad. Preaponeurotic fat, this is the upper lid with the tarsal plate here. In the Asian eyelid, it's thought that this septum inserts further down so that you don't have a skin crease formed here in the same way, and so that you have a more rounded appearance. But there are some studies showing that actually it's the roof, the retroorbital retroocularis oculi fat that is able to descend down here, and that may be something that we see in aging as well. And so in some patients, you actually have to dress the roof, and in some, it is thought that the roof and the preapo fat are hardly separate at all because the septum is so weak or hardly present. I wanted to move on from the hardcore anatomy to talk about something which I think is slightly more interesting, which is what does all this add up to? What is our notion of beauty? What is beautiful? And again, this goes back to sort of how we interpret the world and where the human part of all this. And so periocular beauty it's absolutely fascinating subject. And there are a whole bunch of different schematics that people try to put to this. So if we look at this particular individual, who you may or may not know, perfect beauty apparently with the eyebrow, you're meant to be able to draw this right angle triangle down to the nasal alar, and you're meant to be able to draw across horizontally from the head of the eyebrow to the tail of the eyebrow. And the peak of the eyebrow should be at the lateral limbus. So this is where the clear cornea meets the white sclera. And if you draw a vertical line there, that should be the top of the lid. And so in a perfect woman, apparently this is what you see. And I of course, given that Rachna is my business partner and good friend, I could not agree more. But this is Miss Universe 2019. And she doesn't have her highest point at the same spot. So I think people try to apply these rules. I'm not sure that how valid they really are, as I'll go on to show in a second. I think there's something else going on. And here's the famous phi ratio. If you look at the intercanthal distance, if you multiply that by 1.618, which is the phi number, you're meant to get the distance of to the edge of the rest of the face. And I calculated this last night, and Rachna actually fits quite well into that. And some of the publications I was looking at did not. So that whether this is a very valid concept or not, I don't know, but it's something that's talked about. The other thing that we have to think about when we talk to our patients is symmetry. And we're all somewhat asymmetrical. And here you can see a picture of Rachna. Here you see a picture of Rachna with a horizontal, her face divided in half and with a horizontal mirror so that she's perfectly symmetrical. And here again, she's perfectly symmetrical. And you can see these look like very different people, but I would argue that neither of them looks natural or as naturally beautiful as asymmetrical Rachna here. And this doesn't just pertain to women, it pertains to men as well. This is a famous English footballer called David Beckham, and these are very famous pictures. But here he is in his natural appearance, and the picture emanates warmth, just like Rachna above, warmth, calm. There's something natural about it. If you look where one part of his face has been mirrored horizontally, there's something slightly uncanny or uneasy about it. And the same thing here, there's something slightly intense, something not, there's just, our brain is just signaling something. It's not quite, he's still handsome, and I guess he's still handsome here, but he's not quite as nice looking as he is here. And here's another picture of David Beckham again, not that I'm a particular fan, but I'm also not a fan. I just don't feel particularly strongly either way. And you can see here, this is a natural looking man, and here are just two slightly less natural looking people. So I would argue less beautiful, as I would say these two are. But this is where it gets a bit strange. So it turns out that we're happy with a bit of asymmetry. We like that, but we also like averages. This is Miss Germany 2002 or 2004, except that it isn't. This is Miss Berlin, who became Miss Germany that year. And this is a composite picture of all the runners-up. Now, this is research from the University of Regensburg in Germany. And here you see these are just a few of the 20 runners-up. And when they took software and combined all these images, this was the composite. And when blinded observers, observers who were not aware of what they were being asked to do, were asked which picture was prettier, generally, we prefer this average face, the average of all these 22 runners-up, rather than the actual winner. And the other thing we like is youth. And so the same group did another study where they took some kindergarten kids here from the age of 4 to 6, photographed them, and then morphed their appearance into a computer to create a child appearance. And then here, if you look at picture number 6, both at the top and at the bottom, that's a natural picture of a woman, which has then been morphed with the child features, either 50% morphed in picture number 1, 40% morphed in picture number 2, 30% in picture number 3, 20% in picture number 4, or just 10% in picture number 5. And so you can see that the natural features in picture number 6 are gradually made more and more childlike as you approach number 1. And interestingly, our brains consider the morphed ones to contain childlike features more beautiful than the original. And these researchers went on to say, suggests why Kate Moss was such a success, or is such a successful model, because apparently her face contains a lot of the elements of children. It has a lot of the childlike features, as you can see here, for example, but with accentuations of an adult, such as which have been accentuated with makeup. And there are a few that in this thesis I read through, there are a few other famous faces which apparently fit this, like Brigitte Bardot and a few others. And so to sum up, what this means is that when we talk about the periocular area, there are a few things we like. So we like a bit of asymmetry. We like average. Apparently, we like a little bit of phi ratio, and we like a little bit of these formulae for where the high point should be. But one of the strongest predictors of what we like is age. So age is a huge determinant of what we consider to be periocular beauty and aesthetics.
Thank you, Jonathan. So I'm going to go from here. We've talked about beauty and we've talked about what we look for in beauty and in youth. And we're now going to talk about what happens to the periocular area as we age. In everything that we do, we want to be restoring beauty and in youth for our patients. So let's assess these areas from all the different layers. Jonathan, you're going to be sharing your slides, so I'll ask you to move forward, please. Thank you. So this is a video that shows a young boy, and I want you to watch the periocular area in particular and just see what number of changes you can see and see if you can count how many different changes you see in the periocular area as you watch it. It's a very quick video, so if you can just run the video, please. I'm just going to let you watch it first and then we can just talk around it. So aging changes start very early on in the early 20s, and they happen earlier in females than in males. If we go back to the video, we can go to the next slide, please. What we want to do is to start thinking about three-dimensional anatomy. So move away from the two-dimensional features and three-dimensional features. And we want to look at what the structural features that we see on the surface and how they represent the deeper changes that are going on underneath. So let's watch the video again and just watch what's happening to these surface landmarks. So the tear trough, which is the lid-cheek junction, the nasojugal fold, and then also in the lower face, the nasolabial fold and the labiomental crease. And you'll see how those lines all end up far lower than where they started off. So you can watch again. The grooves are becoming deeper and the lines are dropping down. Thank you. So let's go to the next one. So just diagrammatically again, the eyelid itself appears to get longer, but actually the lid margin to the lower lid part of the orbicularis doesn't change. What we see is that the tear trough and the lid-cheek junction becomes much lower with age, and the nasojugal fold also becomes lower, and there's a sharper angle. So the earlobe itself is probably the only thing that stretches. We also see some ptosis of the nasal tip and deepening of the labiomental crease. So we're going to talk about all of these little anatomical shifts that are happening, and we have to start to conceptualize this in the different layers to better understand why it's happening, and so that we can better understand how we can restore it back to youth. So in youth, the vectors are all pulling up, and in age, unfortunately, everything is going down. Next slide, please, Jonathan. Thank you. So this is a concept that I think is really helpful to understand what might be happening. Tensegrity. Tensegrity is integrity through tension. So it's not talking about the integrity of Barack Obama, who we've already met in a previous slide. It's not talking about the tension that you might have with this great white shark, with this wonderful diver called Ocean Ramsey, who dives with sharks, and some beautiful, beautiful videos and pictures if you are interested. But what we're going to do is now have Jonathan star in this video. He's not only a superb surgeon, but he's also a DIY enthusiast. And he's going to demonstrate this concept of tensegrity. So you see these two metal plates on the side, and they're held together just by string under tension. We gave this talk last year to a global oculoplastic audience, and not this particular talk, but talked about tensegrity. So Jonathan has made this structure, which are two separate bits of wood, and they're held together with just air in the middle by string under tension. I think you put that together in about a day, didn't you, Jonathan?
It was the most preparation we did, I think, for the whole talk. Actually, it took the longest.
So yeah, just to have a look further, so to test his hypothesis that this is going to be able to support great amount of weight, used his very young son Teddy to demonstrate the principle that actually he can balance on air just by means of tension between these two bits of wood. So imagine those two bits of wood are now bone and skin, and everything in between is held plump and tight. But when everything deflates with age, then we have a not very happy patient and not very happy Teddy. I think that was one where you captured him balancing without any support.
Yeah. So now that there's less tension, you can see that the structure is less stable. So it's moving much more now because the ropes have stretched.
But this is what is happening in our faces, in our periocular area, in our brow area as we get older. We lose the tension for various different reasons, and we're going to have a little look at why that might happen. Lovely. Yeah, you could go on to the next slide. Thank you. Okay, so let's just start with bone. Does the bone actually age? What we do know is that the bone continues to grow even after we reach adulthood. There were some studies that were looking into bone aging, and in the face and particularly in the orbit, the facial bones increase by about 5 to 7% between adulthood and senescence. So this growth slows down as we get much older. When the orbital bone grows, then the whole orbital volume also increases. We see an increase in the height of the orbit, so the orbital aperture height increases, as well as the width between the medial and lateral orbital rims. But with age, what happens if you have a look at the blue arrow in youth? This is a CT, three-dimensional CT of a young child and their orbit, and the one below is of a old-aged patient, again a three-dimensional CT. We look at what happens to the orbital rim in the superior medial area. The bone here recesses and resorbs, and so there is an increased height of the orbital aperture here, and there's an increased height of the orbital aperture also laterally. In females, the inferior lateral orbital rim resorbs and recesses, and in men, it tends to be the entire orbital rim. So with this bone resorption, if you can go on to the next slide, please, that has impact on the soft tissues around it. We look at the brow area first of all. Jonathan already mentioned earlier that the frontalis muscle stops short of the lateral tail of the brow. As the bone resorbs, then we start to see brow ptosis, where the tail drops down. We start to see prolapse of the roof fat, and we also see in the upper lid, where there is resorption of the bone superior medially, prolapse of the fat. And so, Jonathan, I don't know whether you could just point that out here in the medial upper lid, that there is this area. Very often we see herniation of the fat here, and that is as a result of partly resorption of the bone that is happening in the superior medial area. That the muscles in that area also will be affected in terms of their support, as well as the fat that you saw in an earlier picture in the central glabellar area. If you look now at the inferior rim, Jonathan, if you don't mind just pointing that out for our delegates again. So inferior laterally, there is resorption more in females, the whole inferior orbital rim in males. And so that bony support again is lost for the ligaments and for the muscles and structures above that. So we see this descent of the nasojugal fold, we see the descent of the tear trough, and we may see herniation of the fat, as there is in this particular picture. Lovely. Next slide, please. So those lines that we saw earlier in our youth and in age can partly be explained by changes that happen in the bone. What do you think happens to the canthal attachments of the eyelids? Having talked about where the changes are, we see actually in youth and in old age, the canthal attachments stay put, so they don't descend, although it appears to descend because we see rounding of the lateral canthus, and we often see rounding of the medial canthus. Now, this is really important because when we're trying to restore our patients to their youthfulness, particularly with lower lid blepharoplasty surgery, we don't want to be lifting or adjusting the position of where the canthus is attached. We may want to sling, we may want to strengthen, but unless we particularly want to alter their position for a particular reason, then the canthus needs to stay put. Thank you. Next slide, please. Okay, so we have lots of fat pads around the face, and those fat pads are what gives us the lovely plumpness of our youthful face. In the periocular area, as you know from the anatomy that we've discussed, there is virtually no subcutaneous fat in Caucasians in particular. But fat in the orbit and fat in the face ages slightly differently. What do we see that happens with age to the fat in the subcutaneous area? Well, in the forehead, if you look at an older person, their forehead is very often atrophic, particularly high up. We have loss of subcutaneous fat there. We have loss of subcutaneous fat in the glabella and also around the orbit. But we also see collections of fat and herniations of fat because of loss of support. And you see that particularly in the medial upper lid, as we saw in the previous picture, in the malar area and also below the tear trough. So next slide, please. The SOOF descends and causes deepening of the nasojugal line, and the malar fat pad also descends due to loss of support, and you see deepening of that nasolabial fold. Next slide, please. What I want to point out in this slide first is that in the upper lid, you've already heard that we only have these two fat pads, the medial and the central. The lateral fat pad of the upper lid is replaced by the lacrimal gland. And this is really important in our surgery for the upper lid. If we have a structure that looks like prolapsed fat laterally, you have to make sure it's not lacrimal gland, and you certainly don't want to be resecting it. About 10% of people with age have a prolapsed lacrimal gland, and it's important to identify that and then address that, and that can be sutured back, and we'll talk a little bit more about that with our next talk. So in the glabellar area, the forehead, the support is lost with the recession of the superior medial orbital rim, so we very often see that bunching up of the fat in between the eyebrows. You see the herniation of the medial upper lid fat pad, and that particularly happens because of thinning of the septum that holds that fat back, but also due to resorption of the bone and loss of support. In the lower lid, the three fat pads very often coalesce to form one sausage. So you see this sort of long, if you can show that again, Jonathan, please, this sort of elongated sausage shape of the fat, but that can be separate in separate areas as well. So sometimes the fat coalesces here to form one whole. And then the malar fat pad, again, as it descends, makes that groove in the nasolabial area much deeper. Thank you. Next slide. What happens to the ligaments? So the ligaments are important, and it's important to know that actually these ligaments are present and show their attachments in youth. So we have osteocutaneous ligaments, which are the orbicularis retaining ligament and the zygomaticocutaneous ligament. And you can see in the picture on the left, the boy in youth also has a tear trough. He also has this apparent line where the zygomatic cutaneous ligament is. And it's really important to counsel our patients when they come to see us because they don't like the appearance of their tear trough. This is present in youth, and we don't always have to destroy it. With age, you see prolapse of the orbital fat. That makes that palpebromalar groove, which represents the orbicularis retaining ligament, more noticeable. And the zygomaticocutaneous ligament, as we showed in the video earlier, has moved down. Thank you, Jonathan. Next slide, please. Okay, and then we get to the surface. So we see all of these changes on the surface, and they represent changes in the skin, in the fat underneath, in the muscles, and also, as you've heard, in the bone. But skin loses collagen from the age of 20. We lose collagen 7 in particular, which provides the support and elasticity and plumpness and hydration of our skin. In youth, our skin is often very uniform, glowing, hydrated, with very little pigmentation. As we get older, the muscles of the mimetic muscles around the face and particularly around the eyes. You heard all about the orbicularis and the procerus, depressor superciliaris, and the corrugator muscles, which depress the brows. They continue to work underneath this constantly dehydrating skin. And the first areas that we notice the lines or the wrinkles are, as was mentioned before, between the eyebrows, the 11s or the frown lines. Very often this happens to females earlier than males, but it can be present and variable in males as well. We start to see the crow's feet, which are the lateral lines due to contraction of the orbicularis muscle. And we also see the deepening of the nasojugal and tear-trough ligaments. And this is related not just to the loss of support from below, but also related to the loss of collagen and elasticity in the skin. With age also, we see increased pigmentation and increased ritids and wrinkles, as well as these deep grooves. So if we can go to the next slide. Why do we see this happen more so around the periocular area? So this is a picture we put together, which is based on research looking at skin thicknesses around the face. And the periocular area has the thinnest skin in the entire face. It's around 1 millimeter in thickness. If you look at that in comparison to the glabellar area, which is 1.77, for forehead 1.58. So the early signs of aging are going to present in the periocular area because the skin is very thin. There is little or no subcutaneous fat, and we have lots of muscles that are constantly acting, and muscles continue to become hypertrophic with age rather than atrophic with age. And all of these contribute to all the changes that we see. Next slide, please. Okay, so how can we restore tensegrity? Well, today we're not going to be talking about the surgical side, but we hope that you've been able to appreciate how some of these changes are as a result of changes from the bone all the way up to the skin surface. And so in order to try and improve these, we need to be thinking more conceptually about improving the structure, improving the tension between the bone and the skin and the attachments of the ligaments and the muscle, and improving the hydration of the skin surface using all of the tools available to us. The next slide.
In the next talk that we give, we're going to focus on the role of tensegrity in trying to reverse these changes. And that can either be surgical or through other non-surgical approaches or semi-surgical approaches such as threads, etc. Touching on what we can do to the skin and what we can do surgically, as well as with fillers. And if you don't want to hear any more from us, then these are the sorts of books you can read instead. There's very little that we would know or appreciate that isn't already written in these wonderful books. One here by our friend Guy Masry in California, and Jonathan Dutton, who is a very senior professor of oculoplastics in North Carolina.
Yeah, so and the first one is Rod Roerick and Pessa. They did a lot of research looking into aging. This is I found this a really helpful book for myself. It's not just for those learning, it's for those who are very experienced. It's very important to appreciate what we can see on the surface and how that changes underneath. And some of the texts that cover the surgical side do not cover the topography. So I would highly recommend that one.
And that was sort of it from us for today. we've taken up 40 minutes of your time. Hopefully you enjoyed and learned something from it. And if not, then we'll do better next time.
Excellent talk, Jonathan and Rajna. You brought out all the points I wanted the beginners to hear about the brow anatomy and the age-related changes and what changes in the anatomy is contributing to the age-related changes. So I believe this makes it easier for the next talk when you're going to describe how to change these age-related changes back to where it was and get the rejuvenation. So the very purpose of these 4 talks for blepharoplasty for beginners were to have a structured teaching program starting from the very basic and then gradually build up and then to have the surgical part of it. And the way you have described it fits very well. Thank you very much. And I have to thank Anjana for introducing Rajna and Jonathan to me. Thank you, Anjana, for that. Fasil, you want to add something?
Oh, no, you summarized very well. Thank you very much to Rajna and Jonathan. It's really great entrance for the anatomy. And we look forward to hearing what's going to come next, because these are for all the surgeons, very important points. And the references you have given are also very popular among us too. We love them very much too. Thank you very much. It was really great.
Well, I forgot to say thank you for the tensegrity. Nice concept. And I'm sure this tensegrity can be applied in other regions also, not just oculoplastic. I'm sure it can be applied for facelift, in rhinoplasty, or other places too. So yeah, I'd like to hear more about tensegrity. I'll be waiting for the next lecture on that.
In the meantime, Anju wrote something of us.
Yeah.
She cannot unmute herself, so she sent her sincere thanks and take all the credit.
Thank you. Sorry, yes, I was not being allowed to unmute, but I am now. So yes, I'm happy to take all the credit for introducing my wonderful colleagues to you. As you can see, they did themselves justice, and it's always wonderful to hear them speak. Fantastic talk. Thanks, both of you.
And Jonna, thank you very much for inviting us, Ulis, as well. It's great actually that we can actually, as I was saying before we started, that we can cross over the boundaries. We should definitely not be having isolated surgeons for this area. The eyelid area extends up to the brow, extends below, and as facial plastic surgeons, we very much want to collaborate. And so, yes, it's great that you allow us to come along and speak to you.
The strict boundaries between different specialties are blurring very fast. There's no point in hanging on to those so-called boundaries. That's my view.
No,
I was just going to mention this concept of tensegrity it's not anything new. It's an engineering concept, and it's what keeps the the London Eye together. Yeah. It's a bike, the wheels on a bike. The wires. It's all tensegrity. It's the tension that gives the wheel on a bike its integrity. And so, so it'll be applicable to lots of areas of medicine as well.
It's so wonderful, Jonathan, that you contribute your children to this concept without any fear at all.
I was scared he would fall,
he was in tears for part of it, but
yeah, but you can mute that out, Jonathan. It's fine.
Hisham is with us, I think. Hisham?
Yeah, I really enjoyed it. Thank you so much. Just going back to boundaries between specialties, there's no boundaries. European Academy was created to include everybody. So from the beginning, we had oculoplastics, plastics, maxillofacial, and everybody else. So you're part of us, guys. We are same thing. So that's the idea. So I really enjoyed it. Really nice to see all these beautiful diagrams. I like the asymmetry one because I do that a lot. It's one of my favorites.
Well, I'm a good example of that. So, but it's an important concept because I think a lot of us fail to recognize asymmetry before we treat our patients, and we'll talk more about it next time. But these are really important things, simple things, but important things.
Exactly. Yeah.
When Jonathan was showing your picture, Rajna, I said, he's going around in dangerous waters, you know.
He's always swimming around in dangerous waters.
That picture of the shark, it was actually me in the water there.
Yeah.
But, Rachna and I write these talks together, so we have full input into all the slides, and we enjoy working together, and that's why we've set up our company together as well, because it's nice to have both a male and a female perspective. It's nice to mix and match, and it's nice to work in a team. And so we actually, putting together a talk like this alone is a lot less fun than putting it together with someone you enjoy working with. So
it's all right. I was only compared to Miss Universe 2019, so it's fine. So it could be worse.
If I can just add one thing, I think from a conceptual point of view, I think it's very beautiful that we humans actually prefer imperfection to perfection. So we prefer, some papers don't agree with this, but I think if you look at the pictures, I think there is a truth in that we prefer a little degree of asymmetry than complete perfect symmetry. And because of the lockdown and all the stress that we've been under, I've actually taken up yoga. And one concept within yoga is that you're perfectly imperfect. So even when I'm sort of on one leg, twisted and falling over and wobbling about and looking ridiculous, it's so imperfect that there's still some element of perfection in the imperfection. And I think that the less pressure we put on ourselves to try to be perfect, and instead embrace the fact that we're not perfect, but that we are perfect in being imperfect, I think it does help reduce stress. And I think it can also help our patients see that they shouldn't be aiming for some unattainable standard, which is actually not even natural. So I think there's a lot of good soulful content in there.
The problem is the patients, Jonathan. If you can make the patients believe that, perfect.
I show them photographs so that nobody's symmetric. I published 2 papers on that, on the symmetry. And I tell them something that was taught to me by my mentor: perfection is the enemy of good. You know, this is what we say, because nobody is perfect. We looked at so many faces, 99.1% were really asymmetric. So that's reality. And many nice looking faces, they are a bit asymmetric as well. So that's the idea. So I always tell them that. I always show them these pictures. So I definitely agree with you, Jonathan.
There's hope for all of us.
Alwyn?
I don't know who Gaspi Ropolu is, but thank you for your nice comments.
Alwyn, your comments.
There are lots of nice comments here.
So there's a question which I'm trying to translate, actually. I don't know if from Babken.
Shat neroxytun miban eles asem aprek axperner.
I think we're talking about neurotoxin. Possibly, is anybody able to translate that?
I don't know what language it is.
I'm using the Google Translator. Give me a second.
Or do we have Babken online? Because then we can unmute. Let me see if I can find Babken on here.
I mean, if it's a question.
There. Wait, just a second. I found Babken Kerakosian, and I've asked him to unmute. So let's see if he can you hear us?
Google Translator can find it. I'm sorry.
I'll talk a little bit about neurotoxin anyway, which is important because we will talk more about it next week, but we really want to be assessing patients for surgery if they haven't had neurotoxin in, it's washed out of their system, because we want to know where the brow is at rest before doing any intervention that might potentially affect the position of the brow, and that can be surgery and also improving the volume as well with fillers as well, which can affect the muscle function and position as well. So,
Rachna, we've got to have something to say next time. So you just, we only have this much powder, so let's keep it dry.
Yeah. So I don't know what the question was, but we will talk about neurotoxin next time. So you have to come and listen into that one.
So the next talk is on 18th of April, Sunday, same time. There shouldn't be any confusion next time, isn't it? The daytime saving is over. And we will have Ms. Rajana Murthy and Professor Janathan Rose talking about brow and upper eyelid. And we have Mr. Naresh Joshi to talk about lower eyelid. And the suggested readings are there. The reason we give gap between the talks is for the participants to go through what has been talked today and also to read for the next topic or next webinar. I hope everybody enjoyed. And Hisham, is it time to wind up?
I think so. Thank you so much. It was really great webinar again, and we look forward to see you next time.
Thank you so much.
Thank you, Rajana. Thank you,
Jonathan.
Thank you.
Bye.
Fazal, I will talk